Good afternoon. I'm Dr. John Robertson, and I'll be your host as you participate in this webinar on mental health, substance abuse, and HIV/AIDS. We welcome all our participants and hope that you'll be able to stay with us through this hour and a half broadcast. We have four presenters that will lead you through the webinar, and hopefully that you'll come away with more information about mental health, HIV, and substance abuse. Our first presenter is going to be Dr. Warren Hewitt, who is a retired administrator of the Substance Abuse and Mental Health Administration of our federal government. The second presenter will be Dr. June Gibson, who is the executive director of Our Brother's Keeper in Jackson, Mississippi. And the third presenter is Dr. Rochelle Joe, who is a researcher at the University of Central Florida in HIV and counseling. We also have a wonderful friend and advocate, Miss Diana Williams, who will present her life story and what she has gone through in terms of someone with HIV/AIDS. Again, welcome, and we hope that you enjoy all aspects of this 18th celebration, or not celebration, but observation of National Black HIV/AIDS Awareness Day. I'd like to also thank all of you who have tuned in and know that you thought that this is not a waste of time to be here with us as we recognize National Black HIV/AIDS Awareness Day. I'd like to thank you for your participation in advance and to encourage you as you listen to the presenters to also think of questions that you may want to ask as we have left enough time on our broadcast for there to be questions and answers. We hope to have a lively discussion and interchange. And in order to do that, there are just a few ground rules I'm going to ask us to observe. First, if you are receiving this on a phone, or such as an iPhone, please use the mute as you listen to the presenters. Also, if you're listening on a iPad or a desktop, also please mute unless at the end you have a comment or a question. In addition to a live question and answer, we also will have the capacity of you typing in the information on the chat column, which is on the right-hand side of your screen. Lastly, if by some chance there isn't an opportunity to answer your question as this webinar goes live, please let us know exactly what questions you have, and we will relay them to the relevant presenter, and so that they can get back to you at a reasonable time. Today, our webinar is entitled The Connection Between Mental Health, Substance Abuse, and HIV/AIDS. And we recognize the theme of today's and this year's National Black HIV/AIDS Awareness, that theme being Together for Love, Stopping the Stigma of HIV. And this highlights the efforts over the years that we have attempted to lower the rates of HIV by providing educational information, encouraging individuals to be tested, and most critically, encouraging people to get involved. And your contribution to this effort can start today by the kind of involvement and hopefully the information that you get from this webinar. Moving on, many people may ask, well, why is there a Black HIV/AIDS Awareness Day? And I remember the question when we started back in 2001. And the very simple answer to that is that prior to this, despite disparate efforts across the country, there was no voice of the community that was expressing the particular problems, concerns, and viewpoints of our African American population. The idea for this came through a group of 10 national African American organizations that had gathered together under the auspices of the Center for Disease Control in a special series of grants that were designed to encourage individuals and encourage organizations in our African American communities to respond to, at that time, the epidemic of HIV and AIDS. That series of grants was initiated by a presentation by one of the foremost leaders of the early efforts in HIV/AIDS, Dr. Benny Prim. And there was an amount of information that was gathered together that Dr. Prim and a group of other concerned African Americans presented to the Congressional Black Caucus. The Black Caucus, when they heard the shocking and staggering statistics about the epidemic of HIV/AIDS in the African American community, went to work, and they tasked a number of agencies, CDC, the HRSA, and 2 other agencies to make the efforts at preventing, treating, and educating the populations of African Americans and the general community about HIV/AIDS a major priority. So, as part of this, these groups, when they met, felt that while their efforts were significant, there needed to be a premier effort that symbolized the importance in which the African American community was taking and regarding HIV/AIDS. Out of this came the first National Black HIV/AIDS Awareness Day. And interestingly, the campaign was put together in less than 6 weeks. So when you talk about how and what we can do, back then there was an effort to get together because it was thought to be so critical. Today, HIV/AIDS is still disproportionately felt in the African American communities. We do have many more individuals surviving. We do have treatment, but still, the latest statistics on HIV and infections are that we still are over 43% of the new cases of HIV in the US. And that while the rates of HIV infection are declining, we still are at a significant disproportion in terms of existing infections and new infections. So today, we wanted to provide a perspective, a viewpoint, and a reminder that the struggle is still not over, that we still have quite a ways to go, and that we have among our presenters individuals who continue the fight in their own way. And so, as an agenda, we are going to have a presentation by Dr. Warren Hewitt, who is a former SAMHSA program manager, whose focus is going to be on substance abuse and HIV/AIDS. Next, we'll have a presentation by Dr. June Gibson, who is the executive director of Our Brother's Keeper in Mississippi. And I say Mississippi with all that that means, good, bad, and ugly, okay? And also a presentation by Dr. Rochelle Joe, who is an assistant professor at the University of Central Florida. We also had in our agenda as a lead-off a friend and colleague, Diana Williams, who was to be our lead-off presenter. Diana has a very sick family member, her daughter, and so she is on her way to us, coming from Tampa. So we've had to modify our agenda a bit to accommodate her, taking care of her family. So with that, I'd like us to then move on to the rest of our agenda with Dr. Warren Hewitt. Dr. Hewitt, would you just grace us with your presentation?
Well, welcome everyone. Let me start this out by, I'm not going to talk a whole lot about HIV. Everybody knows. I just want to bring us back a little bit. Remind us that in 1981, when the MMWR published observation of among a group of gay men, and at the same time talked about opportunistic infections among a group of gay and otherwise injecting drug users in New York City. That sort of began the discussion of HIV. That sort of began the discussion of HIV in communities across the land, but it wasn't until much later that we began to talk about HIV among African Americans. And let me sort of correct John a little bit. The efforts by Benny Prim et al. To start the minority AIDS funding really represents the second phase in the funding of minority programs in HIV. The first one began in 1989 and was funded by the CDC with a lot of support, moral support, not monetary support, from the Office of Minority Health. And we got those programs going around the country, and 3 years later, they were all gone. Part of the epitaph of minority AIDS in this country, of African American AIDS in this country, is the up and down nature of funding that has brought so many great people to the table to be part of the healing in the village, only to find them gone 3 years later. So we have to observe that. The second thing we have to observe is that this epidemic was never always about gay men. They're a critical issue in HIV in the history and in the current realm of HIV, but it wasn't always about them. It was about injecting drug users in New York, in Baltimore, in DC, who were the silent minority, so to speak. The ones who lived and died with AIDS far sooner than a lot of their gay counterparts. And that population of folks, represented a critical inroad into the HIV infection in the African American community. not just because they were injecting drug users, but because they represented the people around the block, around the corner. They were our family members, and they were the ones who became so vital in the early stages of the epidemic. I want to also remind folks that while this has been about injection drug use for many years, in the middle of the 80s, we experienced crack cocaine. And unfortunately, our epidemiology didn't follow the epidemic of crack enough to associate crack use and HIV. But when we started to look at gender, in particular African-American women who became infected with HIV, a lot of the scholarly articles began to realize that one of the critical sources of infection during the mid to early 90s was crack cocaine, because it affected the sexual risk behaviors of males and females. Today, we have, sort of set drug abuse aside, and it wasn't until the 2015 when we saw a small town in Indiana suddenly experience an epidemic of HIV among a group of white male and female injectors who were injecting prescription opioids, Ipana, and then subsequently heroin. Now, this naive group of users were not educated as we were in New York and Baltimore and DC about risk behaviors, about cleaning your works, about being infected by sharing needle and syringes. So they shared, and as a result, we had an outbreak of HIV. And then people began to look and say, well, we have a problem of an epidemic in the rural communities of America. They began to say, well, there's an opioid epidemic, a synthetic opioid epidemic. Now, concurrently, while we were beginning to see all the notoriety in the major newspapers around the country and on TV, we started to see a high rate of mortality, overdose deaths, that were associated with injectors who had been early injectors during the 1960s and the 1970s. These were older men primarily, but some women as well. Men at my age with, issues with coronary heart disease, cerebrovascular disease, diabetes, and hypertension, who were going back to using, and they weren't able to titrate their doses because of the introduction of fentanyl into the supply of heroin on the streets. So consequently, in New York, in Philadelphia, and Chicago, and Washington, D.C., we've seen a major overdose rate, death overdose rate among this population. But in the papers, we still recall that it's a rural community disease. And of course, the president, in citing the importance of this epidemic, stated that he was going to invest billions of dollars. And so they did invest and are investing billions of dollars in medication-assisted treatment, Suboxone, buprenorphine, and methadone. But the question that remains for us, is it hitting our streets? Are we beginning to see the resources to address this issue in the African American community? And then, of course, there's the secondary question, maybe even the primary question, because many of these men, as injecting drug users, are also at risk for HIV and hepatitis C. And so our resources to treat them, targeting their risk of overdose, is not focused entirely on that, but also focused on the risk for HIV. And that's a critical issue for us. not just in the urban communities, but in the rural and semi-rural communities of African Americans. 53% of our people live in the South. And to compound the problem in the South, not only do we have injection drug use going on there, but we have high rates of STDs, chlamydia, gonorrhea, syphilis, exist in those communities in almost epidemic proportions. And the problem is that all of these populations are affected. So the question for us on this day of HIV in the African American communities, what is our investment going to be? What are our priorities going to be? And how do we reconcile the fact that drug use continues to be a major factor in our overall risk of HIV in the African American community, and also represents one of the dimensions, one of the factors that so affects what our future looks like. Thank you.
Okay, thank you, Dr. Hewitt. You've given us quite a number of things to think about. I'd like to now move to our second presenter, and I want to say an old friend, a seasoned friend, okay? Dr. June Gibson, and in the midst of Mississippi. Dr. June, you're on.
All right, again, June Gibson. I'm the CEO of My Brother's Keeper, located in Jackson, Mississippi, and I'm going to address the MBAD from the clinical perspective. On February 5th, 2019, President Trump had the State of the Union address where he stated that we will end the transmission of HIV by 2030. Now, if you work in this field, you probably had two takes on that. You know, for one, it's like, oh my God, I mean, are we really going to be able to continue the national every-age strategy? Are we going to be a part of another presidential administration, which is very exciting. But then on the flip end, you're thinking to yourself, how can this come out of this man's mouth when he has taken an extraordinary amount of length to eradicate healthcare? You have either tried to repeal and replace ACA, and when you couldn't do that, you just poked holes in it. So it could become a basic insurance policy, one that really doesn't help, doesn't provide someone with what they need. So it was perplexing to me that this can come out of his mouth, and it made me wonder, does he not know what he has done? Or is this just more fluff? But regardless of it, whichever one it may be, it is up to us to hold him accountable for the statement that he made on TV that it has been published, that we know that he actually said it. There is no fake news in this particular aspect of things. So in my opinion, we not only have to advocate, but we have to know what to look for. How do we know that we're actually moving this way? And if you're going to give it this much effort and put this date behind it, we should be very strategic about what we want to do. So in my opinion, I think we need to strengthen the relationship between the medical community and public health. Now, mind you, our people have been traditionally disenfranchised from the healthcare system. This is the norm. So if we build a fabulous healthcare system, that does not mean that they're going to come. But in hindsight, the public health system has been the medical system for our community. They go to the health department. They go to community-based organizations. Public health addresses the social determinants of health, the things that is actually in their locus of control. So if we reposition funding to actually fund the marriage between the medical community and the health and the public health system, I feel like we could make a huge difference. That would mean that we would actually put monies towards transportation. I mean, if you want me to access your clinic, I need a way to get there. Also, we need to put money towards food. Me seeing the physician and getting a prescription does not mean that I'm going to be able to take the medication. And we need more money towards housing. I can get the medication and the food, but if I do not have a home to go to, a stable environment, how am I expected to really survive? How can I stay undetectable? And if nothing else, if we can't do anything, We need to put mental health at the forefront of all healthcare, not just HIV positives, all healthcare. Black folks weren't just disenfranchised with mental health, it didn't exist for us. We were born into trauma. We wake up every day traumatized. And so we just got to a point where we live with it, we deal with it, we pray about it, you go to the pastor. But just like when you break your arm, you take that to the doctor. If you break your brain, it also needs to go to the doctor. So we need to ensure that our communities understand the importance of mental health and how it can not only get you into care, but it can keep you into care. So the movements that we have to make over the next 20 years to get this done, I know that we can do it. And I expect from him the same amount of energy and fervor that he put into building that wall. I want the exact same energy to go into reducing the transmission of HIV by 2030. Thank you.
Thank you, Dr. Gibson. Okay. Thank you, Dr. Gibson. Okay. Very, very good, very good. I also wanted to ask you, if you could just tell us a little bit about the work of our Brother's Keeper, because you all are doing some remarkable work and have over the years with the resources that you have. So could you just touch on that a bit?
Yes, my Brother's Keeper has been around about 20 years. And in 2013, we saw things were changing. The community was changing, how funding was changing, and we decided that we would go along the healthcare model. But we did not want to lose the community-based organization. So in 2013, we opened Open Arms Healthcare Center, which is the first and only primary LGBT healthcare clinic in the state of Mississippi. And we're the first LGBT primary healthcare clinic in the South. And this clinic has really shifted how we do things in Mississippi. Our viral suppression rates at the clinic for Black MSM is better than the nation numbers. Our HIV suppression rates for our clinic is better than the nation and the state. So we have made moves by doing exactly what I said. We married the medical community and public health. So the clinic isn't just operated by the medical community. Lay people are in the community. Community-based people are in the community. So within the clinic, you have your primary health care, but we also have patient navigation. We also have mental health. We have emergency food assistance. So it's a food pantry on site. We also provide transportation. So all these things are things that we found that will benefit our community. And I feel that it has changed how we do healthcare, but it also has introduced a group of people to healthcare who never had it. Men don't get the chance to go to the doctor for their annual at 16. And so now we're inviting men into healthcare that they've never thought that they would have. And so men, for the first time that I've seen, go to the doctor. Young men, 21, 22 years old. We also are the only PrEP clinic in the state of Mississippi. So all these things are happening in one spot, and it is absolutely amazing. We recently got a 38-foot mobile clinic. That's a statewide unit that we travel across the state conducting what we call our BHU, our Becoming a Healthier You. So basically, the BHU is going to be glucose, cholesterol, BMI, blood pressure, HIV, syphilis, gonorrhea, chlamydia, Hep C, and Hep B. It's an opt-out package. So we're going to give you everything. And we introduce you into healthcare, and we provide services through telehealth. We work with the hospitals. So it's a good marriage, and I know that it works. So when we talk about doing this the next time and the best way to do it, there is a model for it, and we're not a federal qualified healthcare center. We are a community-based organization using a different model that most community-based organizations can use. We're not all going to be federal qualified healthcare centers, but what we can be is better, and hopefully we're able to get there.
Yeah, thank you. I'm glad. Thank you, Dr. Gibson. And because the work that you're doing is just so critical, especially in the area that you're in, that I thought it would be critical that presenters and our participants know just what you're doing with the resources that you have. Okay? Again, thanks much. We're going to move now to our research aspect of the presentation, and that is Dr. Rochelle Joe, who's at the University of Central Florida. Dr. Joe, you're on.
Thank you, Dr. Robertson. Hello, everyone. So I want to give me a little background on me so that there's a perspective of where I'm coming from. I am at the University of Central Florida, and I am faculty in our counselor education program. So what I do is prepare master's level students to be school counselors, clinical mental health counselors, and marriage and family counselors. And what has been an important part of that work for me is preparing them to appropriately serve individuals affected by HIV and AIDS in a way that is culturally informed and ethical, in line with best practices. So when I approach the topic of mental health and HIV, especially in the African American community, I'm thinking about that from someone who is preparing the people who would be professionals serving this population, and knowing that there is a gap in knowledge for mental health professionals that is a concern, because we know that stigma is real, and we know that, especially in the African American community, we are hesitant about accessing mental health services anyway, and that is compounded when HIV is in the picture. So it's critical for me to do everything that I can to help prepare professionals to be the face and to be able to be present with individuals affected by HIV in a way that will encourage them to come back and continue to get that mental health support. Of course, as was mentioned by both Warren and June, this mental health aspect is critical. We know that with HIV, there's a co-occurrence of anxiety, grief, loss, depression, substance abuse, and those issues exacerbate the medical concerns for people who are living with HIV. Now, coming from a counselor's perspective, I'm very interested in wellness as a framework, because that is really our approach to the work. So thinking from a holistic perspective, how are people well in all of those ways? So not just their physical health, but also their social relationships, their ability to cope and to care for themselves, their sense of spirituality and connectedness to other people, and also their sexual wellness. So thinking about their own sexual health and all of the factors that go into that. So some of the research that we've been doing is looking at a wellness framework for both HIV prevention, but also for those who are living with HIV. We know that when we often, from a medical model, talk about illness, there's a focus on the disease and not as much of a recognition that an individual might be living with HIV and have a very full life and experience wellness in multiple aspects of that. And that's an important piece for mental health professionals to recognize, is that HIV is a serious illness. We know this. We also know that people can experience the trauma of an HIV diagnosis and bounce back from that. We know that post-traumatic growth is an experience that is real. And that's borne out in some of the literature that is out there as well, that although people may experience the trauma associated with the illness, that there are opportunities for growth, particularly if people have the social support and the access to care that they need to take care of all of their needs. Sort of building off of what June talked about and holding our current president accountable for the things that he said related to goals with HIV, I think it's important for us to consider the continuum of care, the HIV continuum of care, because that's really what he's speaking to. We know that that when individuals are aware of their HIV status and are connected to care and are adherent to that care, that they can achieve a suppressed viral load. And we know that that is key to their own mental health and physical wellness. And we know that that's also important for reducing the number of HIV transmissions. And the key part for the mental health piece is that we know that at every stage of the HIV care continuum, mental health plays a role. We know that mental health plays a role, mental health and wellness plays a role when we talk about HIV prevention. So if we are working with adolescents or adults or even couples, we want to explore aspects of their sexual wellness and what are their plans to protect themselves related to HIV and what might be the barriers to that. We also know the same is the case when we're talking about people taking an HIV test. There's a great deal of anxiety that can be associated just with getting a test and the unknown of what the results may be. And so there's a role for mental health professionals to play there in exploring risk with clients, establishing a commitment to a testing routine with clients, dismantling whatever social or emotional mental health barriers might be in the way of them getting tested and knowing what their status is. And then for those who are HIV positive and who've received that diagnosis, again, as mentioned before, there can be a trauma experience there. And so mental health professionals who can be in that place to help process that trauma can help get individuals who are positive connected to care. They can also help them to remain in care, to really fully engage in care, and to be an adherent to medication. There are multiple counseling approaches that can explore medication adherence with people living with HIV. Motivational interviewing is one that's often used to explore what might be someone's resistance to adhering to their medication, or what might be very real obstacles to adhering to their medication. Some of those were mentioned by June earlier: access to, food, access to shelter, access to all of that medical care that they know is very critical. And then if we can't explore those things with people in a safe place where there's a lack of judgment, then we're not necessarily going to get them connected to care, engaged fully in care, and adherent to their medications. So all along that HIV care continuum, there are different mental health components that have to be explored. And we know, of course, surrounding this whole issue are questions about stigma, about the language that people use regarding HIV, about beliefs that we have about sex and sexuality and drug use that prevent people from getting tested, from knowing their status, from engaging in care, from adhering to their treatment because they're ashamed and don't want people to see them, taking their medications. So those are all things that can and must be explored from that mental health perspective. And again, as I mentioned before, as someone who works to prepare counselors to do this work, if they don't even know that these are the issues, then they won't be able to engage their clients fully in a holistic way to help them get to that goal of being virally suppressed. Not only that, but living a full, whole life. So I think those are the key points. I don't know if you have follow-up questions for me, Dr. Robertson, but I think those are the key points I wanted to discuss regarding the mental health piece.
Yeah, thank you so much, Dr. Joe. Yes, there was one, and that is, and this links to the presentations, in terms of the funding of both research and the funding of culturally competent programs, such as yours out at University of Central Florida. Can you just speak to that a bit, if you want to call it the challenges, or the I don't want to call them barriers, but the kind of challenges that may be posed, because I know that many institutions have attempted to support HIV counseling services, HIV research, but often the funding tends to wax and wane through the political climate.
Yes. Yeah. Well, no, I'm not concerned there. I do think in my particular university, there certainly is support, and there has been some financial support for some of the work that we've been able to do. I would say, of course, when we're talking about going for federal grants, it's highly competitive. And when you're a new kid on the block like I am, nobody knows who you are. Nobody wants to give you money. So what my experience, of course, right now has been to do what we can with what we have and make use of as many human resources as possible. So I established a research team called HEART, HIV Education Awareness and Research Team. And it's graduate students, undergraduate students, and faculty who all think that this is a really important thing. And so we engage in outreach activities, we engage in some awareness raising activities on campus, we conduct research, and we have done some pretty cool things with very limited funds because people think that this is important. And so I would say that, you know, funding is going to be what it is, and a lot of that is kind of out of our control. But being able to get the buy-in from people, and especially people who have influence and have time and resources to offer, I've found that to be invaluable, especially at this stage, because that creates a buzz. So then I'm not the only one doing the work. There are lots of other people who are doing this as well, and maybe it's because I helped them to see how important this was, but then they go out and they get their own research going and their own grants going, and so there's sort of like a butterfly effect from there. So, but the funding is there, especially through NIH, the National Institute of Mental Health, especially when we're talking about health disparities. So given that we're talking about the African American community, there are opportunities. It's just a matter of being able to land them.
The reason I raised that is okay, I have to remember to take off my mute every time. The reason I raised that is I was talking to a researcher at a prominent African American educational institution that I shan't name, but talked about how they were at a predominantly white college, and then wanted to be closer to home and moved to the DC area. And the difficulty was that there was very little problem in getting grants when they were in Los Angeles. But after moving to this Washington Institute, and talking to the same people for some of the same grants, all of a sudden literally the funding complexion had changed. And I don't know if you'd be prepared to comment on that.
Well, I think that funding sources care. No. Right. Well, I mean, I think that funding sources want to know what you're going to be able to say you're going to do and manage the fund well. And there may be some assumption about your ability based on reputation. Yeah, I got an echo. No, I'm good now. Yeah, but that, I mean, I think that that's kind of the, I'm not surprised to hear that. I mean, I do think that people want to make sure that you're going to do what you say you're going to do and that you can manage the money well. And there may be some, sounds like there might be some bias in that example that you gave.
Okay. Now, just to be sure, that's a very limited sample, so I don't want to characterize that as the essential problem, but I think that researchers, and correct me if I'm wrong, that research funds at times, depending on the institution itself, can be very, can I call it ephemeral? That it can be there at one moment and not there. And I think the only reason I want to raise that is as research continues, as you know, that being able to follow up and to be able to see a whole series of research efforts reach fruition tends to be very important. And so one of the things that I'm going to segue a bit, and this is to a question that, for me is very important, and I think to some of us who are involved in the National Black HIV/AIDS Awareness Day campaign, and that is, do you think that campaigns like NBAD, the acronym for the National Black HIV/AIDS Awareness Day, do you think that that they serve a role in changing some of the perspectives on stigma and perhaps even impacting actual rates of infection in the African American population? And this is for any of us, any of the presenters.
Well, I can respond. I think absolutely the answer is yes, because nothing else we can for me. I've got an echo going. I don't know what I need to do. Okay. I think that if nothing else, we can information. I don't know what I need to do.
Oh. Mute. No, that's it.
Okay. Yeah, I think we're sharing information. So we're increasing the awareness within our own community, but also an opportunity to educate other people about social determinants of health, health disparities. I think it's reducing stigma. The less we talk about something, the more it's going to be a problem. And I think the more we talk about HIV in our community, the more mobilized the community itself will be. And I think it also matters who's saying what. So when we have individuals who are really advocating around HIV, who are from our own community, I think that matters. I think it also matters that we have not just Black women and gay Black men, but that we also have straight, cisgender Black men who are having conversations about HIV and talking about the epidemic, so it doesn't get marginalized to something that is affecting subgroups within our community that we might not care about if we choose not to care about. It has to really be a centered concern within our community, which means everybody's talking about it, including pastors, including just all of us in the community, to reduce that stigma and really engage in the conversation so that we can move forward. Because when it's marginalized to particular groups, then as a whole community, we can care about it less because it doesn't affect us.
Mm-hmm. Okay, good. Thank you for that input. And as you meant, Dr. Joe, thank you for your input. And as you mentioned in your comments, the role of community organizations, and particularly the church. And I just want to comment very briefly. We know that there is one premier organization, Balm in Gilead, that has attempted to be a center point for the dialogue around HIV/AIDS in the faith community. But I also have become aware of some additional faith organizations.
One in particularly that I'm aware of because I'm involved in their mental health task force is the Union of Black Episcopalians. And I was pleasantly surprised about 3 years ago that in a national meeting that the issue of mental health was raised. And with one of the churchmen, one of the clergy, who happened to be a bishop, who in an open forum admitted his own struggle with depression over many, many years. And the interesting thing was that it allowed many of the attendees to perhaps for the first time in conversation with each other admit that either they or family members had had issues with mental health. Out of that came another set of discussions around such thing that's HIV/AIDS. And now the group each year, this is the second year, recognizes both World AIDS Day and National Black HIV/AIDS Awareness Day in its church calendars, and encourages the churches, particularly in the African American community, to have dialogue, to have various informational forums and communications with the leadership taking on the task of carrying that information to the congregations. So I just wanted to comment on that, and I believe that there are some groups that are within a non-denominational faith groups that are attempting that. So in touching on that, it seems that the leadership in whatever organizations there be, the faith community organizations, etc., that the leadership needs to be some of the folks both becoming more educated and willing to step up and taking that matter of perhaps self-disclosure or disclosure of family members who are close to them, that this is something that we are living with. This is something that is not next door, but at times may be living in our homes. So I just wanted to again see if any of our other presenters might want to comment or to just elaborate on that a bit. And if you will, since I've aside from talking, I've got some of you muted. If you want to do that, just raise a finger like they do in church. Okay. Dr. June? Okay. Go ahead. Go ahead.
Well, you need to, okay. Well, from my perspective, I would not mainstream National Black HIV/AIDS Awareness Day. There's no reason to take it out. I mean, it is our day, and we know when we go mainstream, whatever we have is coveted. So it'll be taken away from us. And so we should brand all our Black as long as we can, as long as it's relevant. We know the country is changing. We're going to be brown and gray. By 2050, we will have I think there will be no majority race. Everyone will be mixed. By 2025, we would have 3 times as many 100-year-old people than we have right now. So the country is changing. So one day we may not have to do it. We may not have to say Black. But today, right now, we should have our day. We should have our rap. We should have our Black American pageant. We should have our HBCUs. There's absolutely nothing wrong with us branding who we are and being proud of it. And particularly because for so long, we were not allowed to be ourselves. So I say keep it the way it is and we keep going.
Okay, amen. I'm going to unmute on that one and say amen. Okay.
Dr. Hewitt, yeah, go ahead, sir. Okay, go ahead.
Am I recognized? Okay. No vibration. All right. I think you're absolutely correct. I think, Dr. Gibson, what you're doing is really what we had the seeds to do years ago in the epidemic, but never got done because of a lot of issues. I think we have to be astute enough to understand that the proposal advanced by the president is not going to happen the way we're organized right now. We need to invest in Black in our community. And you know, one of the shortcomings of the minority AIDS movement that Dr. Prim got started was that it was never allowed to be what the Congressional Black Caucus intent was. It wasn't to fund a bunch of AIDS programs in communities, it was to build infrastructure. Not just infrastructure of prevention, but it ultimately spoke to the infrastructure needed to address the range of issues that people who were affected and infected with HIV struggled with. And that's what I think we have to return to. The idea that we are the village, and in order for the village to thrive, it has to do a lot of things about health and well-being. It has to take on substantive issues of mental health, not just in isolation, but within the context of all that we do. Adherence is a big concept, not just in HIV, but clearly in mental health and clearly in hypertension and clearly in coronary heart disease. When we start to marry those things together in programs for people who are advancing in age. Now, I can see people with HIV that I know very well who are my age. I'm 70 years old. And they have HIV, they're positive, but they're virally suppressed, but they have hypertension too. And they have cerebrovascular issues too. So we have to talk about the range of things that are consistent with where people are on the life continuum in our community, and do that with institutions that we build and build together to address not just HIV, but the range of health issues that we face in the community. That's me. Amen.
Okay, well said. I have some folks here who are Dr. Hewitt, I have some folks here who are trying to clap quietly so that we don't get a further echo. But your comments were well received and well taken. Now, I had one other question that came to mind, and that is, in terms of your role, and this is for each one of our presenters, that in your own way, how do you see your professional or personal role in aiding in the effort to reduce HIV and AIDS rates among our African American and also among the general population? And we'll have to stay in church and so that I can just select one at a time. So who wants to take that on first? Okay, now, okay. I was about to say that. Okay, now, church, come on, give me a word. Okay, go ahead, Dr. Joe.
Okay. So again, speaking as from a professional perspective, as a counselor, educator, and a researcher, as I said before, I take very seriously my responsibility in preparing culturally informed, ethical counselors who are going to go out there and really do good work serving the population. And I would also say that along with that, as I mentioned before, we engage in awareness raising activities. We do some education for our own students. We've done events for HIV testing day so that they understand what the experience is like for various people who are going to get an HIV test. Last weekend we had a counseling conference where we had a panel about integrated care for people living with HIV. And we heard from pharmacists, a physician, counselors, to talking about how they can work in interprofessional teams. So I think that's one way that I think that, we can really help is by preparing good professionals to do the work with people who will need mental health services. I would say also in terms of research, looking at what are best practices, also looking at what might be some HIV prevention frameworks that we can use, particularly for adolescents. I'm in the state of Florida where comprehensive sex education does not exist. And that's part of the reason why we lead the country in new HIV transmissions. And so HIV prevention for young people to help them really understand themselves in a holistic way and understand how their sexual health and wellness connects to all of those pieces, I think is a really important piece for that on the prevention side, so that we can reduce the number of HIV transmissions. We know that we're not to zero with HIV transmissions, so there will be people who will contract HIV, but if we can explore what might be protective factors, if we can equip young people with the knowledge and the skills and the self-awareness to be able to make proper choices, then we can prevent some HIV transmission. So those are ways that I see myself professionally being in that. And I would say, in terms of personally, for me, the professional is very personal. So I really put kind of my heart into all of this work that I do because it is personal to me. So, I live this every day and have conversations even amongst, people that I know, not in a professional way, just about HIV, especially here in Orlando, where we know that HIV rates are really, really high. So I'm always having this conversation.
Dr. Hewitt? Oops. Thank you, Dr. Joe. Dr. Hewitt, go ahead.
Can I talk now?
Yes, you can.
Did I get recognized?
You have been recognized, sir.
Thank you very much. It's important that we educate the people, but we have to do that on a continuous basis. One of the things that's happened to us over the years in this epidemic is that as each generation has flowed into the epidemic, they flowed in without context, without history. They've reinvented things that were already there. And they've encountered new problems that the brain trust was not there to help them with. I think it's real clear that in our community, we have to keep people at an elevated level of knowledge. But there are a number of people who have gotten so tired of HIV, who believe, as so many of the people on the news media say at times, that we've turned the corner. We're talking about eliminating HIV. I'm not one of those who believes that we can eliminate HIV in 10 years, not unless we have a major effort in communities like ours to build infrastructure, to build a voice in the community. And so I think it's really critical for us to continue the educational process, but not make the same mistake that we made when I started in this process years ago. And then that was that we talked a lot to each other and not a lot to the rest of the world, and not a lot to the rest of the community. We did a lot of good work, but we didn't broaden it sufficiently to address the community at each stage in their development. My vested interest in this is not me per se. I have 13 grandchildren that I want to see HIV free throughout the duration of their lives. So that's my That's my burn to do this kind of work.
Keep on burning, because that flame still sounds like it's bright and strong. Okay, Dr. Gibson, go ahead for him. Okay, Dr. Gibson, can you hear me?
You're on mute.
Okay, go ahead.
Okay. Oh, thank you, Warren. 13 grandchildren, that's awesome. I too feel the same way. I have a daughter. Though I only have one, I feel that my role is to take these minorities, my little brown and black babies, and just pull them into everything that we do as much as I possibly can. We actually have programs where we are training the youth. We're training biomedical students. So our chemistry and biology students, they may want to be physicians, but we introduce them to public health. We get them to understand and to become tolerant now. So they're working at the clinic. So they're working LGBT, they're working with HIV, they're doing STDs. And so we're normalizing it now. So when they become physicians, it's just a regular thing for them. It's nothing that's so shocking. And at the same time, we also have a residency program for nurse practitioners, MDs, and pharmacists. And so they work in the clinic. They learn about transgender care. They learn about HIV care. So I kind of say it's the 80-80 model that we're using, where we want to ensure that we can catch it on the front end and the back end to be able to make a holistic change. And I see it. I see their faces when they come in as a biology student and leave as a public health student. So they wanted to help. They knew they wanted to serve the community, but they thought the only way to do it was to become a physician. And so when they find public health, it is like a light bulb comes on. And as this country changes, we need more people that look like us to be in public health. I mean, we will have to change it to ensure that we get what we need. So if I'm nothing else, I would like to say that my contribution, MBK's contribution, Open Arms contributions, that we will make Mississippi better. If we don't get anywhere else, and that's a hard job. That's a very hard job. But we will make Mississippi better. And hopefully, if you can do it in Mississippi, you can do it anywhere.
Let me say one thing. Dr. Gibson, you sound a lot like somebody I knew in Mississippi a long time ago, Aaron Shirley.
Yeah,
you know
Dr. Shirley. Yes.
Medical mau-maus are needed.
Yeah. It takes a lot to work here. It takes a lot. But, gosh, I had no idea.
And June, that's one of the reasons that I felt that it was really important to have you in the midst of the South to be involved, because often in the large cities the resources are easier to access. The availability of funding is a bit easier, but your work, and it's interesting, I don't think that it's by chance that one of the founders of the National Black HIV/AIDS Awareness Day, Dr. Mark Colomb, came out of Mississippi, came out of that environment, and was, in his own way, an HIV mau-mau. Okay. And so I think that spirit, as we go through the various elaborations of our struggle against HIV, that spirit remains. So, and for me, at times, Warren, I'm a couple years ahead of you in terms of being seasoned, but the thing that keeps me going is that sense of looking at those individuals like a Dr. Benny Prim, like a Mark Colomb, like a Lou Harris, like so many of our colleagues that have gone before us,
and who continued the fight when it was not only not popular, but that there were very high risks in terms of their positions, their livelihoods, and for some, their reputations and their safety. So when I think of that, we truly, and I feel that I truly stand on the shoulders of giants. Now, I may have shrunk an inch or two over the years in that standing, but being able to continue the struggle is absolutely critical. And at some point, I had said that, as in that famous poem, I think by Claude McKay, I was ready to lay my black flag down. But in this day, age, and time, professionally, being able to carry the word, to carry the mission of spreading that word of education, of involvement, of the sense that we need to continue the fight, because again, if we don't, who will? And so while again on this telecast, it is my hope that we may have had more listening in. Your efforts in participating will not go for naught. We will be making copies of the telecast. We'll be putting it on YouTube so that it'll be downloadable by you or others who want to utilize it. And we hope to follow this by a continuing effort, which may be annual or more frequent, to have informational and educational dialogue like this. Because if you think of the four of us on this broadcast as carrying that flame, there are many individuals who are working, literally in the trenches, and the administrative offices, etc., who need that sense that there are others out there that are carrying on, that are willing to continue the fight, and who feel that it is not a waste of time to be able to focus in on HIV and AIDS. So with that, if there are any other comments, I can take them now. If not, I really want to thank each and every one of you for your insight and your communication. It makes me proud and humble that my colleagues are still fighting that fight, fighting it well, and urging me on to do even more. So I thank you. All right. So with that, I think we have done our task for the day. I'm going to close out now, and when we have this ready for broadcast, I'll also send a follow-up email, and if at that point you want to add any additional thoughts or resources, please feel free.
I put resources in the chat box so everyone can see.
Oh.
I put the resources in the chat box.
Oh, Kendra said that she put the resources for anyone that had called in or was part of the broadcast, that it is in the facing page as you come into the broadcast, and you can access it afterwards, by just coming into the meeting, and you'll see those resources that are there. Okay. So at any rate, with to everyone, let us continue standing together with love, and I look forward to talking to each one of you very soon. Bye-bye, and be well.
Thanks.
Thank you.